Before we get started, I'm going to be introducing Dr. Sinclair, who is an internationally renowned expert in diabetes and clinical gerontology, specializing in the care of older adults. He founded the Foundation for Diabetes Research in Older People at Diabetes Frailty and has held prestigious positions such as Professor of Medicine at the University of Bedfordshire and Dean of the Bedfordshire and Hertfordshire Postgraduate Medical School. Currently affiliated with University Hospitals, Birmingham, NHS Foundation Trust, and King's College in London. He does research on diabetes, frailty, and older people, leading to several high-profile publications. He has provided expert guidance for the UK NICE, British Geriatric Society, Diabetes UK, and the Care Quality Commission, and served as the first national clinical lead for diabetes in older people at NHS Diabetes. He also chairs the European Diabetes Working Group Party for Older People and the Multi-Professional National Advisory Panel on Care Home Diabetes. So he has contributed with multiple publications and international guidelines, and he's an expert from the World Health Organization in frailty. In 2013, he was awarded the International Gerontology Presidential Medal.
Well, hello, my name is Alan Sinclair from London, the United Kingdom, and it's a great pleasure to give this webinar talk on frailty, sarcopenia, and diabetes. I think Jorge is marvelous to have established the Global Frailty Network, and I hope that you will find my talk interesting and informative. Because of the technical delays, I think that I will ask for comments at the end of my lecture if there is time. But if you have any questions, please reserve them to writing to me, and I can give you considered responses. Next slide, please. As you can see, there are a number of colleagues I wish to acknowledge in the preparation of this talk, particularly Dr. Ahmed Abdelhafiz from Rotherham in South Yorkshire, United Kingdom. We've written over 35 papers together in the last decade, indicating our mutual interests. Next slide, please. Work that I undertook for the International Diabetes Federation is presented in this slide. The table at the foot of the slide shows predicted data on the dramatic rises in diabetes and aging populations globally over the next 20 years, and an increase in overall prevalence to about 20%. Can we go back? Looking at the color-coded descriptions of numbers of older people with diabetes per region or country, with the darker burgundy red color showing high rates of diabetes, it can be seen essentially as a global pandemic affecting nearly every continent, which is evidence of a highly prevalent and often ubiquitous disease. What this figure does not show is the tremendous economic burden of the personal and socio-economic impact that accompanies this disease process. Next slide, please. The relationship between comorbidities and frailty in diabetes is not only fascinating, but is also complex. We cover this later. The ILSA study, led by my good friend Stefania Maggi, former president of the EU GMS, showed that in terms of disability, diabetes-related complications and comorbidities shown here in the slide can only account for part of the disability seen, and raises the question, what else could be operating that might account better for the level of impairments, disabilities seen in older people with diabetes. Press next, please. So, no, go back. Sorry, please. So, as it says at the foot of the slide, in terms of disability, classical comorbidities only explain 38% of such adverse effects of diabetes in women, and only 16% in men. Next slide, please. Here we see the results of PARC studies in the US. using data from more than 1,800 subjects aged 70 to 79 years in the Health, Aging and Body Composition study, showing the accelerated loss of muscle and decreases in torque in the lower limbs of subjects with diabetes following 3 years of follow-up. This will be briefly mentioned in the recording later. Data from both knee extension, shown on the left, and hand grip, shown on the right, are given. It should be noted that although some degree of accelerated muscle loss occurs in the arms, no significant differences in muscle strength or quality is demonstrable between diabetes and non-diabetes. Next, please. Thank you. Next, please. In 2008, our group carried out the largest case control group in the world of older people with or without diabetes in the over 65-year-olds. We examined functional loss, and our focus was activities of daily living and instrumental activities of daily living and cognition. This attracted the attention of Reuters, the media mogul, who summarized this work and its finding as demonstrating that diabetes in older people causes physical disability, when at that time the focus was indeed on the micro and macro complications of diabetes. We developed a predictive model for mobility limitation, but sadly, I did not pursue this line of research, but we may come back to it later. Next slide, please. 5 years later, this finding was confirmed in a Lancet review, where a systematic review meta-analysis showed conclusively that diabetes was indeed significantly associated with mobility disability, IADL disability, and ADL disability, as shown on the chart on the left, showing the odds ratios and risk ratios of excess disability from more than 10 studies on the left of the slide. Next, please. Abdel-Hafiz and I recently published our views on the proposed comorbidity frailty pathways leading to disablement. This is a diagram of that, of the work we presented. This is a complex slide and could be used as a basis for a tutorial if you were wanting to do that. Essentially, the two index concepts, once created, are pathways that lead to functional decline and new disablement. The morbidity and frailty pathways become interchangeable, and this is what's important. And the degree of disablement depends on the patterns of this multimorbidity and the severity of frailty. Sarcopenia does not have to be a major feature in these pathways, but in general is often seen as a key stressor to increasing the risk of frailty. Next slide, please. For the final 3 slides before the recorded presentation, I wish to touch on a study that Leo Rodriguez Mañas from Madrid and I led on as a European Union funded project called the Mid-Frail Study. It involved 9 European countries, nearly 1,000 subjects aged 70 and over with either pre-frailty or frailty, as determined by the Freed score. The intervention was a multi-component one consisting of resistance exercise given for 16 weeks in year 1 and year 2, nutritional education, and medical optimization of the blood pressure and HbA1c according to the guidelines of the European Diabetes Working Party for older people. The control group carried on with their usual GP care. Next slide, please. This slide shows data after 12 months. The physical performance in the intervention group, as measured by the SPPB, the short physical performance battery, is shown as the orange-colored points on the graph significantly improved compared with the control group shown as the blue points. It is important to note that improvement in performance is still present at 12 months, although the intervention of resistance exercise stopped at 16 weeks only. The study also showed that the intervention showed a cost savings in terms of reduced hospitalizations and GP visits. Next slide, please. The final slide before my recording shows that further analysis of the mid-Frails findings after 1 year were published recently and are shown in the abstract here. You're not expected to read it, of course. It shows that 3 main outcomes. Firstly, that the multi-component strategy was associated with an improved quality of life score using EuroQual. Secondly, that the probability of lowering of a deterioration of both the quality of life and the Bartel ADL was present. And thirdly, that in order for these achievements to be present, that participants had to have more than 80% adherence to the intervention. Otherwise, these benefits were not seen. And this is important information. And essentially, the results of the mid-Frails study are not widely known. And yet, for the first time, this was an intervention study in diabetes in older people, which actually improves physical performance and reverses the effects of frailty. So would you now please look at a video recording that I did for the ATTD in Florence earlier this year. It will mention some of these things, but I think it will put sarcopenia in its correct light. Thank you very much, Jorge, for showing this video.
Good afternoon. My name is Alan Sinclair, and it's a great pleasure to be part of this symposium at the ATTD with such good friends and colleagues. My lecture describes the emerging topic of diabetes, sarcopenia, and frailty, and how, in clinical practice, we might understand their quite remarkable interrelationships. You will see during this lecture that all 3 conditions have many features in common. There are 3 key objectives, as shown here, which are related to establishing the features of type 2 diabetes in older people from a multi-domain perspective, describing key interrelationships between the 3 conditions, and managing frailty and sarcopenia in a setting of diabetes. Work that I undertook for the International Diabetes Federation is presented in this slide. The table at the foot of the slide shows predicted data on the dramatic rises in diabetes in aging populations globally over the next 20 years, and an increase in overall prevalence to about 20%. Looking at the color-coded description of numbers of older people with diabetes per region or country, with the darker burgundy red color showing the high rates of diabetes, it can be seen essentially as a global pandemic affecting nearly every continent, which is evidence of a highly prevalent and often ubiquitous disease. What this figure does not show, of course, is the tremendous burden of the personal and socio-economic impact that accompanies this disease process. On the left side of this slide is presented the definitions of both sarcopenia and frailty with the relevant codes. It can be seen that sarcopenia is seen as a distinct disease of skeletal muscle where both muscle mass and power are affected. The definition of sarcopenia has been enhanced by the work of the European Working Group. The definition of frailty is approached via breed physical phenotype or Rockwood's cumulative deficit model. A key feature is loss of physiological reserve and homeostatic failure, depending on the severity of frailty. On the right side of the slide, we can see that all three conditions have many features in common, and I have listed 6 of these. The chronicity of each condition, combined with altered homeostasis, emerging functional loss, altered glucose dynamics, and distinct muscle changes represent the important commonality of all 3 conditions. This represents a schematic view of the varying influences on aging muscle tissue in older adults with diabetes. Quite clearly, various comorbidities and direct complications partially explain the level of physical deterioration we see in aging individuals with diabetes. It is important to highlight that insulin resistance related to having diabetes and an intrinsic feature of aging muscle, development of sarcopenia, will increase by the accelerated loss of muscle seen in diabetes, as shown by the elegant United States studies of Park and others. This also results in loss of power, increased insulin resistance, which can also lead to autophagy of muscle cells, activation of proteolytic pathways, and accelerated muscle protein degradation. The diagram on the right of the slide shows that the 3 conditions are interrelated in terms of the etiology of lower limb dysfunction through increased fatigability, muscle weakness, decreased endurance, and sarcopenia. Inevitably, such a sequence of events leads to disability. I have considered diabetes to be primarily a disorder of muscle, along with the other manifestations we see, including beta cell dysfunction, peripheral resistance, and so on. In this slide, we see 3 aspects of this. Here we see on the left CT images of the thigh muscle demonstrated age-related decreases in muscle mass and quality of muscle with fat infiltration. In the middle, we see the results of Park's studies using data from 1,800 subjects aged 70 to 79 years in the Health, Aging, and Body Composition study. This shows the accelerated loss of muscle and decrease in torque in the lower limbs of subjects with diabetes following 3 years of follow-up. And on the right, we see data from the Korean sarcopenic obesity study showing a higher prevalence of sarcopenia in subjects with diabetes, confirming that diabetes is an independent risk factor for sarcopenia. The relationship between diabetes and sarcopenia is less well known amongst physicians. In the previous slide, we saw data from the Korean sarcopenic obesity study, and we complement this by showing an emphasis on these relationships in the next 3 slides. A meta-analysis of observational studies has demonstrated that the presence of diabetes itself, diabetes complications, and in fact high HbA1c levels lead to an increased risk of sarcopenia, just over double the risk. In the 4 sets of plots shown, these associated odds ratios are shown for diabetes itself, age, presence of diabetes vascular disease, and specific complications. In terms of the management, in the clinical scenario, lowering or optimizing glucose, which reduces the risk of prediabetes and conversion to diabetes, early use of metformin to reduce the risk of progression of diabetes, and and also to reduce the risk of complications seem to be sensible therapeutic options. We require clearly more data from future studies. A further example of how the prevailing level of glycemia can have a profound effect on muscle mass and function can be obtained from this Chinese study in older adults with type 2 diabetes with or without sarcopenia. Using continuous glucose monitoring for 3 days and examining the incidence of sarcopenia and the parameter time in range, logistic regression analysis showed that time in range was a protective factor, and in those studies with higher levels of time in range, the incidence of sarcopenia was progressively lower. The coexistence of type 2 diabetes and sarcopenia was shown to have a significant increased mortality in hospitalized subjects that were prospectively evaluated after discharge in this Brazilian study. Sarcopenia was shown to be higher in diabetes subjects, 46.5%, and was assessed by the Get Up and Go test and grip strength and calf circumference. The graph on the right shows the survival curves over 2 years in the various groups studied, with the lowest survival seen in the group with both diabetes and sarcopenia, equivalent to a doubling of mortality compared with a control group. In contrast to the sarcopenic studies, we must recognize that the relationship between diabetes and frailty may be better known amongst clinicians. We know, of course, that diabetes is associated with considerable morbidity and mortality, but less well understood is the prospective relationship between diabetes and frailty, or the methods explaining this relationship. The first study shows the results of a large prospective study from Spain in older adults examining the association with diabetes and risk of frailty, where one of the key investigators was Professor Leo Rodriguez Mañas, who is part of this distinguished panel of experts today. During a mean follow-up of 3.5 years, 115 cases of incident frailty occurred. Compared with the non-diabetic group, diabetic individuals had a doubling of the rate of frailty as defined by the Fried criteria. The study concluded that this increased risk could be partially accounted for by unhealthy lifestyle behaviors, hyperlipidemia, and by hyperglycemia. In this study, we see evidence of a reverse association in which the syndrome of frailty can be shown to increase the risk of diabetes mellitus. This study also involved a large prospective cohort of older community living people without diabetes in the Padua region of Italy. After a mean follow-up of 4.4 years and using various Fried criteria shown on the upright axis for diagnosis of frailty, evidence that both pre-frailty, a 60% increase, and frailty, 87% increase, increased the risk of diabetes in the 265 cases of incident diabetes. These previous slides, which demonstrate the varied interrelationships that sarcopenia and frailty have with diabetes subjects, they enable us now to have a clearer picture of the multiple domains that comprise a modern interpretation of what type 2 diabetes is in older adults. In summary, 4 of these characteristics are shown here, relating to the global high rate of this metabolic condition and its age-related association, a model of high heterogeneity and high vascular risk, a disease of accelerated muscle loss and propensity towards sarcopenia, and type 2 diabetes being seen, therefore, as a complex illness requiring a multi-domain perspective and intervention. We continue to a further 4 characteristics of type 2 diabetes in aging older people. It is seen as a condition of high multi-morbidity, a significant risk factor for frailty, a significant disabling state, and a chronic disease where diabetes technology has a lot more to offer. These 8 characteristics provide us with a modern perspective of type 2 diabetes in older people. Working with Ahmed Abdel-Hafiz and Leocadio Rodriguez-Manias, our detailed review of these interrelationships of the 3 index conditions attempted to describe the intricate pathways that lead to physical dysfunction and the key adverse outcomes of failure to maintain independence, care home placement, and hospitalization and disability. In a setting of the aging process and the interaction of genetic, environmental factors, and comorbid chronic disease, biological processes at the molecular, cellular, and physiological levels generated by the diabetes state all lead to frailty, which often involves a precursor state of muscular dysfunction and loss of lean muscle mass in the legs. In essence, a sarcopenic state. However, we feel that sarcopenia is not an inevitable substrate for frailty. Once frailty develops, further deficits accumulate, involving homeostatic failure, increased vulnerability to stressors, and functional loss, which in turn leads to disability. Frailty must be seen, therefore, as a pre-disability state. It is now time to briefly talk about management perspectives, and in this situation, these are more of clinical importance. There are a number of generic requirements, I feel, that are present in the management, general management, broad management of frailty, sarcopenia in a setting of diabetes. Here we show 5 points that underpin goals of therapy, and these range from preventing the conversion of pre-diabetes to diabetes, lowering insulin resistance, optimizing blood glucose levels, and optimizing nutritional well-being. From the viewpoint of the clinician, avoiding polypharmacy and seeking advice from the international guidelines can assist. Studies such as the Mid-Frail Frailty Diabetes Study and the SPRINT trial of frailty and sarcopenia will emphasize the importance of multi-component strategies. And I am certain that Professor Rodriguez-Manias will cover these to an extent in this symposium. Finally, I'll now introduce the concept of metabolic phenotypes of frailty in diabetes, which I feel can offer the opportunity to lead to a more effective and precise treatment. In a sense, we are moving towards precision medicine. Ahmed Abdel-Hafiz and I have now published several papers on the subject of frailty, metabolic phenotypes in diabetes. We have previously undertaken a systematic review to define the degree of metabolic heterogeneity and metabolic profiling in frailty, bearing in mind that frailty subjects can be thin with weight loss, obese, have muscle loss, may have lowered glucose, or be hyperglycemic, and may have varying degrees of insulin sensitivity. We considered that from a wide metabolic spectrum, we could define 2 common types: an anorexic malnourished type with a significant weight loss at one end, and a sarcopenic obese type at the other end, which would have visceral fat accumulation and muscle loss. The features of the anorexic malnourished type are shown here, emphasizing the weight loss, decreased HbA1c, lowered insulin resistance, and lowered cholesterol. Here we see that a diabetes trajectory would, in a sense, be decelerated, and a de-intensification approach would be appropriate, and if necessary, early use of insulin based on its anabolic properties. In contrast, the sarcopenic obese individual, characterized by increased body weight, increased HbA1c, muscle loss, and high insulin resistance would be seen as an accelerated diabetes trajectory and necessitate an intensification approach to therapy. This group would benefit from an early use of SGLT2 inhibitors or GLP-1 receptor agonists. Based on these findings, we have published guidance on the management of non-frail and frail individuals with diabetes and have created, in a sense, an algorithmic perspective. This is shown here, and on the left of the diagram, we see the traditional three-step approach to managing glycemia in a non-frail, independent individual. On the right, we see the same three-step model applied to the frail individual with diabetes, but we have separated the treatment arms primarily into the anorexic malnourished type and the sarcopenic obese type. A further initial separation of the anorexic malnourished group into those that have poor oral intake, where early use of insulin is warranted, and a compliant oral group where you can institute a three-step approach where metformin and or a DPP-4 inhibitor are used with insulin reserve for later use if necessary. Separation of the sarcopenic obese type into those who are metformin tolerant or intolerant enables us to individualize even further. Using the three-step approach, for instance, in those intolerant of metformin, early use of an SGLT2 inhibitor or GLP-1 receptor agonist appears to be a sensible approach. There is a growing interest in carrying out studies in diabetes and separating out those into varying degrees of frailty. On the left, the DELIVER trial of dapagliflozin and heart failure. Frail individuals with diabetes were recruited using the Rockwood accumulative deficit model, with the primary endpoint being a time to first worsening of heart failure event or cardiovascular death. Although greater frailty was associated with worse outcomes, the benefits of dapagliflozin were consistent across all frailty levels, and quality of life improvements greater in those with severe frailty. On the right, a Danish study examining the initiation of SGLT2 inhibitors and GLP-1 receptor agonists in subjects with type 2 diabetes, cardiovascular disease, and frailty. They found a lower probability of their use with greater frailty despite their benefits. Clearly, once all this evidence has been reviewed, there may be a call to influence modern guidelines on glucose lowering in frailty. To conclude, for the present and near future, we must accept that we require a multi-domain, individualized management plan for the treatment of diabetes, particularly type 2 diabetes in older adults. This is particularly so for diabetes complicated by frailty with or without sarcopenia. Emphasis should continue on effective glucose-lowering algorithms, de-escalation therapy, lifestyle changes, frailty and comorbidity management, and developing the roles of medical technology in diabetes self-management. Precision medicine is important, but the evidence base, particularly in older people, needs strengthening. Thank you very much.
Okay, I think I haven't seen any questions yet.
Okay.
Yes, let me, just one sec. Oh, sorry.
I hope that presentation. Hello, Yogi. Can you hear me?
Yes.
I hope that presentation was clear. And to save time, Yogi, I think we can jump to the case history that I presented to you. and rather than repeating the messages that I wanted to do initially, because I appreciate that quite a bit of the work on metabolic phenotypes is new to some people, and I would have wanted to spend some time. But if you could show the slides and just move quickly through them to the case history. Yes, excellent, excellent. And so may I start discussing that now? Righto. Thank you. I can start now then. Thank you.
Yes.
Well, first of all, I want to present an example of a metabolic phenotype case within a setting of frailty. And so here on the left is the history and other features. This is a 78-year-old man with mild frailty, but independent in activities of daily living and instrumental activities of daily living. Had type 2 diabetes for 10 years, on metformin, 1 gram twice daily, and lifestyle measures. Recent HbA1c, 64 millimoles per mole, which is moderate control only. Hypertensive on losartan, 100 milligrams daily, and amlodipine, 10 milligrams daily. Recent blood pressure readings, 155, 85, 162, 86, 160, 64. So moderate control only. BMI 35, so overweight stroke obese. Exhibiting a decline in renal function, estimated GFR about 50. No macroscopic proteinuria, dipstick negative. Now, quite obviously of elevated cardiovascular risk, and this is one of the typical types of patients we see in the clinic, and has extensive background diabetic retinopathy, but thankfully no exudates or new vessel formation. So time to manage and treat that and hopefully reverse some of those findings. Next. So in summary, this patient, you would probably agree with me, that has mild frailty, but is still independent. Type 2 diabetes, poor glycemic control, evidence of microvascular disease with the retinopathy, hypertensive with moderate control only, and a decline in renal function. One would hope that the estimated GFR would be above 60 or 70. Declines to 50 indicate that perhaps some improvement is necessary, and specific actions are needed by the consulting clinician. Next. So we asked two questions. Can you say what the assessment and management would be of this patient if you saw this patient in the clinic? And what would you say was the metabolic type that this person is? Anorexic malnourished or sarcopenic obese, or neither of these cases? Have a little think for 1 minute and then I'll move on. Okay, next please. Okay. So let's look on the left at the logic and rationale for this case. Next. Well, considering his obvious cardiovascular risk, he should benefit from the newer therapies. So that's an important point to make. He is frail and obese and therefore has an elevated risk of being sarcopenic. It puts them into the category, therefore, quite simply, of sarcopenic obesity. And we know that this significantly increases the cardiovascular risk compared with the normal, non-frail, non-obese subject. Furthermore, this is the rationale for therapy. Furthermore, the new therapies will reduce his blood pressure down to target, hopefully, or even reduce the need to have more hypertensives or diuretics, thus reducing polypharmacy, which may also have a positive impact on the outcomes seen in this patient. Next. Well, what management steps are also needed and need to be considered? Well, first of all, we have to carry out a number of investigations and diagnoses. So sarcopenia, unless we're going to use DEXA scans, we can attempt to use the five or six item questionnaire, the SARC-F, and the diagnosis could be made clinically. For frailty, we could use the clinical frailty scale, the pictorial clinical frailty scale, or the electronic frailty index, which in the United Kingdom we use in primary care settings. And this would be complemented by the history and observation. What tests would we do? Well, the SPPB, I think, needs to be a test we need to advocate more and more in clinical settings. Hand grip strength is important, but often dynamometers and such like aren't available routinely. Walk speed is something very simple to measure. Lipids, of course, are important, and microalbuminuria is something that diabetologists and diabetes specialists would want to do. Now, for treatment, we would consider an SGLT2 inhibitor such as empagliflozin, 10 milligrams, or dapagliflozin, 10 milligrams, or a GLP-1 receptor agonist such as semaglutide, which can be given by injection, tablets. Liraglutide can be given by injection once weekly, and both HbA1c and estimated GFR would have benefits. Now, in cases of even higher cardiovascular risk, patients who perhaps had a significant past history of myocardial infarction or stroke, both classes can be taken together, and I'll be showing you a slide of that in a short while. And the additional management, nutritional intervention, obviously for managing sarcopenia, although this type of intervention is not routinely available, or even most nutritionists working in hospital settings may not be familiar with how to manage a sarcopenic patient. Exercise training, resistance exercise, of course, is clearly important for building up strength and muscle mass. And then you would either treat them then with an SGLT2 inhibitor or a GLP-1 receptor agonist and review them in 3 months' time. You'd probably set up continuous glucose monitoring, and you'd through a device such as Freestyle Libre or Dexcom or whatever other devices are available in your country. Okay, well, that, I hope you got most of that. I expect you might have done something slightly different, and if it wasn't for the difficulty we have, I'm going to come to that slide, Jorge, those last 2 slides. Do you mind if I show them? Jorge, I think we've got a bit of time. Can we go back? Right, okay. What I wanted to say is, because of the slight technical issues, I'm so pleased that you can hear me but I would have loved to have been able to discuss things with you. And so we'll now go to the final two slides. Right. So I'm going to show you two slides that provide the evidence for SGLT2 inhibitors and GLP-1 receptor agonists, the benefits of giving these in older people with diabetes. I think that's important. But each of these studies need studying, scrutinizing, and there are always minor flaws, even in these published papers. On the left is a meta-analysis of 11 studies examining the use of GLP-1 receptor agonists. And it shows that MACE, major adverse cardiovascular events, are reduced. And on the right, the effects of using SGLT2 inhibitors in older people demonstrates that not only is MACE reduced, but also heart failure and renal outcomes are also improved. So varying benefits indicating that that their use, the threshold for their use in older people with diabetes should be lowered. And finally, in my final slide, we show the effects on the accumulative incidence of MACE, demonstrating that over 5 years of follow-up, combination therapy of these two agents versus either class alone is of superior benefit, and that's shown by the yellow-orange line below the blue line in both graphs. And so we now have the evidence. It's often a brave clinician who will want to prescribe both. And hopefully by prescribing only one of these agents, significant clinical improvement can take place. So I would like to end at that point. I'm so sorry that I cannot hear you, but I do hope that you found the talk and the video of interest to you. I would be delighted if Jorge was able to provide PDF copies of my slides to you, and I would be delighted if any of you would write to me with questions or comments. And thank you very much, Jorge, and thank you to the audience.
No, thank you. I think we ran out of time, but like Dr. Sinclair has mentioned, we have you'll have access to the video of this presentation, so that means the slides, and we'll make them available to you in the next few days. So thanks again to Dr. Sinclair for the wonderful presentation and the very practical advice in managing patients, older patients with diabetes, but specifically with frailty. So that's an important topic, of course, for us. Now, I just want to make an announcement for November 13 at noon Eastern Time. We'll be having a special Frailty seminar series that will actually last 90 minutes. This is the first time we're going to do that. And it will be a panel discussion on the ethics of frailty. I think a topic that has become especially relevant after the COVID pandemic and many issues, especially in Europe and many other countries around the world, related to rationing and other ethical dilemmas that have come up. So I invite you to participate there. 4 distinguished speakers will be presenting and also having an engaging discussion. This is part of a much larger effort in developing a consensus guideline for frailty and ethics of frailty. And I hope that many of you in the audience will be engaged and maybe be wanting to be part of this initiative. So stay tuned for the next Frailty seminar series. Dr. John Muscadere will be the moderator, and we'll have speakers from the United States, South Africa, and the UK, who are well-known experts in frailty and ethics of frailty in particular. I hope you join us. And thanks again to Alan for the wonderful presentation. And we hope to see you again. Take care, Alan.